I think I've made the announcements pretty repeatedly at this point, and our numbers are starting to simmer down. So I feel really comfortable and excited to transition over to welcome our keynote speaker. Dr. Sadie Elisseou is here with us tonight. And you guys, I'm extremely excited, very excited to be able to introduce her and also hand off our keynote opening to her. I had the pleasure of hearing her speak not very long ago, and I was really moved and blown away by her approach to trauma-informed care, not only for the benefit of our patients, but for ourselves as providers. And when I reached out, she was nothing but excited and eager and optimistic to come be our keynote and learn about EMSC. So Dr. Elisseou comes with a really incredible background. She's a primary care physician at Boston VA Healthcare System and a clinical instructor of medicine at Harvard Medical School. She is nationally recognized as an expert in the field of trauma-informed care, and she helped to develop an award-winning curriculum on trauma-informed physical exam, which is actually taught in many medical schools across our country now. This is an area which may be new to some of our providers, but others have heard a lot about trauma-informed care. So we're really excited to welcome Dr. Elisseou to help us learn about not only caring for our patients, but taking care of ourselves. And her objectives are available on the screen, and I'm going to hand it over to her so she can get us started.
Thank you so much for that brilliant introduction. I am humbled and grateful to be here. And I'm just going to share my screen. Let me know if this is not successful. And if you can't hear me, let me know as well. I feel totally honored and thrilled to be kicking off the day. What an exciting time. And I hope that you all enjoy this conference and all it has to offer. I hope that it's a time of learning, a time of connection, and also a time of fun, because you deserve that too. So good afternoon. I'll be sharing some specific practical strategies that I think can transform our workplace culture for the benefit of patients as well as ourselves. I have no disclosures to report. And this is just a brief advisory. I will not be showing any audiovisual depictions of trauma, but this subject matter is a bit heavy. And so please do note that it can be emotionally distressing. And I want you all of us to take care of yourselves in the way that best suits you. Please feel free to get up and stretch, grab a glass of water, go to the bathroom, rejoin later, whatever you need to do. And our objectives are to, number one, explain the relevance of stress, burnout, and trauma in our current work environment, to apply key principles of trauma-informed care to our clinical care of patients. And this, again, may or may not be a new concept for people in the room, but we're going to review it. And finally, understand how a trauma-informed approach to holistic health and well-being can cultivate our own resilience, recognizing, of course, that we already come into healthcare as very resilient beings. We just have tough jobs. So first, to begin with an overview of trauma, I'll share with you how I got into this. When I first started my clinical practice, I joined the VA, and about a third of my patients have PTSD. And it was very clear early on that basic physical exam maneuvers that I was performing in my clinic were making my patients visibly distressed. I remember swinging my stethoscope off my neck to start the cardiac exam, and the patient jumped. I remember approaching someone to check the thyroid in the neck, and he stammered back. And so slowly I started adjusting how I stood in the room and the words that I used to speak, all of this in an effort to set them at ease. I started teaching those strategies to medical students. And one day a student asked me, hey, Dr. E, can you please share more about your trauma-informed techniques? And I honestly thought she had just made that up on the spot. It was like, trauma, what are you talking about? And she explained that actually trauma-informed care is a well-established framework for supporting people who've been through really tough things. And it can be applied universally as a means of building resilience. She also let me know that through a trauma-informed lens, healing happens through people. It's through safe and collaborative relationships, which is really beautiful if you think about it, because any interaction you have with another person can be seen as an opportunity to reverse the impact of trauma. And I thought, are you serious? Nobody has ever told me about this before. It was completely enthralling. I was hooked. I locked myself in my office for a month and read everything that I could at the time that was published on trauma-informed care and developed a formal framework for a trauma-informed physical exam. Collaborating with that student, we had the opportunity to publish that curriculum. We won an award for it, and now it's being implemented, as mentioned, at medical schools across the US. So incredible that to be a part of this movement. And in this ripe climate of stress levels rising globally, unfortunately, trauma-informed care is a rapidly growing academic and social movement. Oprah wrote a book with Dr. Bruce Perry, who's a world-renowned traumatologist, called What Happened to You, and it's firmly rooted in these principles. Kaiser Permanente released a change package to help make their primary care clinics trauma-informed. The Surgeon General of California has established a lot of programming related to ACEs screening, adverse childhood experiences. Trauma is popping up everywhere in the media. I'm being asked to talk a lot more about trauma-informed organizations and leadership. So this is an exciting time to be doing this work. First, just to be clear about what I mean when I say trauma, because you all attend to trauma in the world of EMS. I like this definition because it's quick and catchy. These are the 3 E's. It's any event that is experienced as harmful and has lasting adverse effects. Okay, so that's a pretty broad definition. This is from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. They're real pioneers in the field of trauma-informed care. And what's important here is that this is perceived, something that is experienced and perceived as traumatic by an individual, because we can all go through the same thing, but we have different perceptions of it. For some, it may be traumatic, and for others not. So many experiences from the individual all the way up to the societal levels have the potential to be perceived as deeply stressful. And here are some examples of many. We have many forms of discrimination. We have versions of violence and abuse, including the ACEs that I mentioned, intimate partner violence, gun violence, transgenerational trauma, including war, natural disasters like pandemics, and then the medical trauma, physical trauma, and issues related to social determinants of health that you see all day long. So I highlight this to note that trauma is not just some physical injury, like you're taking care of someone in the trauma bay of the ER, like for a broken bone. This is something that is a lot more expansive, and they're also not extraordinary experiences so far out of the realm of normal, right? These are very common, very human experiences. And we want to note that because trauma is not just for our patients, right? It's something that our staff experience, that our trainees in the learning environment experience, administrators, people on this call, etc. So we'll transition to talking about how trauma-informed clinical care can be expressed with real practical strategies. How can we help people feel safe and empowered? And I'd like to lead you through the 4 R's of a trauma-informed approach. These are also from SAMHSA. So the first R is to realize the widespread impact of trauma. 2 is to recognize the signs and symptoms among our patients and staff. 3 is to respond by putting trauma-informed principles into practice. And then 4 is to finally resist re-traumatization. So we'll go through each of them in sequence. The first is to realize the impact of trauma. And to do that, I'll show you a couple statistics. One national study showed that 89% of the US population will experience at least one traumatic event in their lifetime. That's most people on this call, and trauma can take away our sense of safety and autonomy and trust. And so before I knock on the exam room door to see my patients in primary care, I think, how can I help this person feel safe? How can I help them feel more in control in an environment where they do feel vulnerable? It's just a fact. And how can I help them feel more trusting of me and the healthcare environment? The most famous study ever published in the world of trauma was the ACE study from the 1990s. They surveyed thousands of Americans and asked them whether they had ACEs before the age of 18 in the realms of neglect, abuse, and household dysfunction. And at least half responded that they had one or more ACEs. And since this study has been published, important work has been done to expand the concept of ACEs to include more structural exposures, for example, community violence and racism. So this is all an underestimate. This is an example of an ACE pyramid explaining how ACEs can have a dose-dependent response on illness and lead to morbidity and mortality. At the bottom here are the social and economic conditions that impact our health and contribute to life adversity, particularly when there's a relative lack of psychosocial resources. And so when you have ACEs on top of that, that can actually really change our brain's neurobiology and the development of the early brain. We get high levels of cortisol and norepinephrine and inflammatory biomarkers that can be measured in the bloodstream. All of that can lead to impaired metabolism and impaired immunity. Toxic stress can also contribute to us picking up some perhaps maladaptive coping behaviors. Maybe that's disordered eating, maybe it's alcohol use, and all of that also contributes to illness and early death. So we think about ACEs all the time, of course, in the patient population that you serve. But what about us? There are a couple studies, and these studies are growing in popularity, looking at ACEs among healthcare professionals. So in nursing students, a national study showed that over 40% had an ACE score of 4 or more, which was higher than the national average. And then looking at one medical student body on the West Coast, the rate of 1 ACE or more paralleled, mirrored the rates in the general population. And there are other studies that show that it's even higher than this. So really, this is interesting in many ways. Perhaps some of us join the healthcare profession to a degree to achieve trauma mastery. I can't tell you how many personal statements I've read to get into med school or residency. They start with, you know, when my grandfather was diagnosed with lung cancer, and when I was hospitalized as a child, and blah, blah, blah. These are things that inspire us to do this work. And then anybody who has ACEs, thinking about your patients or yourselves, what do? We come to the hospital or the clinic and we're further exposed to stressful things. It's no surprise to anyone here that these encounters can make people feel vulnerable or afraid or lost, like they have no control. Oftentimes what we do to patients, whether it's putting kids through an MRI or doing a lumbar puncture or surgery, this is uncomfortable stuff. This is often painful, psychologically, emotionally, physically painful. So being aware of this and the fact that the healthcare environment is often a trauma playground, right? It helps me be more patient with patients and helps me be more intentional about inserting some joy, some kindness, some love where I can to help balance that, you know, because we talk about ACEs, but on the other side of it, there are PCEs, positive childhood experiences, and all of that serves as a buffer. So it's a complex world, and we can be intentional about inserting the good. So the second R is to recognize signs and symptoms of trauma, and we'll review that by looking at what does trauma look like. First, in our patients, maybe they're avoiding routine care. Maybe they're no-showing to visits where there are sensitive exams planned. They could be irritable, hyperactive, dysregulated, maybe vague chronic symptoms where all of the workup has been negative so far, some behavioral disorders, insomnia, constipation, eating challenges. These are common in kids. Avoid telling you symptoms that might prompt you to touch them or do painful tests. Maybe they're distracted or nervous or checked out during the visit. They don't adhere to what you're recommending, or severe chronic multi-organ disease should tip you off to some underlying adversity. How about us? What does trauma look like in us in the workplace? I'm going to share a quote here from Dr. Bessel van der Kolk. He's probably the most famous psychiatrist in the world right now, with his book, The Body Keeps the Score, being #1 bestseller again and again. So he shares that there are many signs and symptoms of untreated trauma. However, the most noticeable in a professional setting is a struggle to focus, forgetfulness, chronic fatigue, withdrawal, lack of enjoyment, irritability, emotional dysregulation, intense need to control, hypervigilance, panic attacks, perfectionism, inability to relax, overworking, poor time management, frequent sick days, and behavioral extremes. Whew, that's a lot. So thinking about this list, have you perhaps noticed any of these things in your coworkers the past few years? Have you perhaps noticed these things in yourself? This is a concept from the world of psychology that I really love, and it's pertinent to our discussion here today. It's the window of tolerance. So we aim to stay in this middle zone of optimal arousal where we can think and act clearly at work, but sometimes something activates us to move up out of that window into hyperarousal where we're seriously on guard and agitated. Sometimes, alternatively, things can activate us to move down out of that window into hypoarousal where we're just checked out. Not there anymore, distracted, zoned out. And this can happen, of course, for our patients as well. When you notice that your patients are irritable, agitated, angry, shouting, well, they're probably in a hyper aroused state. And most people encounter the healthcare system teetering on that border of optimal arousal and hyper. And for myself, I could be walking around calm and comfortable, confident at work, and then something happens that really presses my buttons. And the literature shows us that it can be anything that is sensory similar to a past challenging life experience. And I could totally lash out, easily, but we are resilient beings. And so we use a series of strategies to choose to respond intentionally rather than react instinctively. And I'll just share one that I like using. I learned this from Dr. Eric Gentry. If you turn your attention to the body, try to see if you can intentionally release any constricted muscles. So relax any furrowed eyebrows, release any tension in the jaw, allow the shoulders to drop, release the hands, and notice how that feels. Perhaps a little bit more in the moment, perhaps a little bit more relaxed. This is something that you can do dozens of times per day. It uses the body to send a message to the brain that the brain can interrupt that threat response. We don't have to be hyperaroused anymore. We don't have to have the body feel like it's in danger, like it's in an active threat. The brain can know, all right, we are safe and it's okay to become regulated again. Many different versions of grounding techniques, which is an example of what I just showed you. That's just one. So let's move into the third R of responding by putting trauma-informed principles into practice. And we'll do that with a look at communication. Communication between you and your patient should be easy to understand, no medical jargon. You're not going to say, I'm going to palpate this, maybe press. You're not going to say percuss, maybe tap. You're not going to auscultate, maybe you'll listen. It should be gender affirming and patient preferred language, minimizing the power differential between you and them. Accommodate everybody who speaks different languages and address the social determinants of health rather than blaming or shaming the patient, and focus on their strengths. What is right with them? What is strong with them rather than what's wrong with them? So I'd like to give you an example of trauma-informed communication. Our communication can be nonverbal, verbal, and written. And so here, perhaps you're greeting a patient. And you could say, Jeffrey, I'm Dr. Elisseou, nice to meet you. Or alternatively, you can say, nice to meet you. I'm Dr. Elisseou. How do you like to be called? So which of these perhaps is more trauma-informed in communication? In the first one, we're making an assumption or a judgment about what this person's name is. But in the second, we're trying to get to the patient's preferred language and to be gender affirming as well. Even in my adult older patients, if I walk into a room and say, hey, Mr. Jones, sometimes I get, Mr. Jones is my father, please call me Timothy. So a second example here, perhaps one of your patients discloses a past history of intimate partner violence. You could say, I'm sorry that happened. Do you feel safe now? Or you could say, I'm sorry that happened to you. How long were you in that relationship? What do we think might be a more sensitive approach? The more trauma-informed option here is the first one, because it doesn't necessarily matter what are the details of that past trauma history. We're not here to take a trauma history unless you're a licensed mental health professional who's in treatment with the patient, specifically with the goal of mitigating trauma-related symptoms. In a trauma-informed way, all that stuff doesn't really matter. What matters is, how are you right now? Are you safe right now? How has this impacted your well-being? And what are your goals for getting well? How can we partner together on those goals? And finally, I'll show you a written example of communication, which is more and more important these days as patients have access to their written electronic health record. This is a summary statement or a one-liner, the kind of thing that we would say to each other or write in the chart. Jeffrey Thompson is a 17-year-old homeless patient with a history of medical noncompliance and alcoholism who's here with poorly controlled type 1 diabetes. I've written this sentence like hundreds of times in different versions over the course of my work. And perhaps now is a good time as any to rethink how our words matter and how they may be read by other people, because our verbal communication influences our team members' view of the patient. The written documentation gets copied and pasted again and again in the chart, and patients have access to it. So perhaps instead of homeless, maybe this is someone with housing instability. Perhaps medical noncompliance, not able to adhere to current treatment plan. Perhaps instead of alcoholism, alcohol use disorder. Perhaps rather than poorly controlled, which is, tough language, maybe diabetes not at goal or diabetes with an A1C of 14. So you see there's a shift in the paradigm from the traditional and accusatory, what is wrong with you? What is wrong with that patient? To the more compassionate inquiry, what has happened to you? What has happened to that patient to influence them in this way? What's behind those behaviors that I am seeing, right? Because when we go through something very, very difficult, oftentimes it shows up as fear, and we get these really anxious, needy patients who are constantly, at least for me, sending lots of messages, new symptoms every day, or we get anger, and that can show up as rage and irritability, and they're aggressive, they fight with their words and sometimes physically. But thinking that, interesting, this is probably coming from a place of pain can transform that. Finally, we'll be talking about the 4th R of resisting re-traumatization. And for this portion, I'd like to focus on the physical exam, and I'll share with you an abbreviated version of my framework for how to speak and behave before, during, and after a physical exam. And a more complete version can be found online. So this framework is really just a guide. These are suggestions, they are tips. I will tell you that I have 2 children, but I really don't know anything about taking care of them clinically. So you are all experts in the room about how to do this kind of an exam with the pediatric population. I'm probably not going to give you super helpful, unique tips related to that. And also thinking about the own exams that you perform. Hey, perhaps they're already trauma informed. Or perhaps not. I would say that most of us enter the healthcare profession with compassion and with this mission-driven intention to serve, but this is not always an inherent skill. This is often a learned skill. So before the exam, we're going to make sure that our nonverbal communication is appropriate. Whenever possible, try to sit or stand at eye level with the patient rather than towering over them, which would enhance their feeling of vulnerability. And make sure that try to limit sudden movements or loud noises, although many times in the field, those are things that you cannot control. I set an agenda for the exam. Sometimes I even name the body parts I'm going to examine. At least in primary care, some older gentlemen come in wondering if I'm going to do a rectal exam. And so stating that we're just going to check the heart and lungs can feel reassuring. And even in pediatrics, like people think, oh, I'm going to go to the doctor and get a shot. I'm going to go and they're going to do a genital exam. Well, maybe not. Set that agenda. Make it standard. This is something we do with all patients who come in for XYZ visit, not done uniquely just for you or for no reason. Identify what concerns, if any, they have. Before you start, you can even ask them, have you had difficulty with this kind of exam in the past? Ask what you can do to make them more comfortable. Sometimes in pediatric population, maybe if you have a minute, they can grab their favorite stuffed animal or put on their favorite sweatshirt or grab their blanket or bring a loved one into the room. And speaking of loved ones, offering a chaperone is important. Historically, Institutions have mandated the presence of a medical chaperone for cisgender female patients undergoing a breast, genital, or rectal exam. Now, 99% of my patients have always been male, and they're the ones who have taught me the impact of sexual violence. So this is a call to think more broadly about this. In addition to a medical chaperone that is perhaps required, you could ask the patient to invite a loved one or support person into the room as well. So that's before the exam. Now, during the exam, you're going to attend to draping and comfort at all times. For children who are old enough to move their own clothing and draping, I recommend that you ask them to do so rather than you being the one to move it yourself. That's their shirt, their pants, not yours. And expose the minimum body surface area at any point, making sure to redrape the patient once you're finished. Introduce the exam components that you're going to perform and explain why it's being done. Now, you don't have to stop every single step of the way and explain the medical relevance of everything you're doing, but just make sure that it's known that this is being done for medical reasons, not because you want to look at their exposed body and touch their body. Ask permission before touching their body, especially sensitive body parts. Stay within their eyesight while respecting personal space, and I'll show you some examples of this. Use simple clinical language, and I'll also show you examples of that. Check in with the patient periodically and as needed, and be efficient with your exam. So in the first photograph, I think, okay, well, got to listen to the lungs, posterior lung fields, maybe I'll stand behind the patient. But she can't see where I am or what I'm doing, and that can be unnerving. In the second photograph, I'm standing at her side within her peripheral vision. The stethoscope reaches. I still get the same data that I need, but it's maybe more comfortable for her. For generations, doctors like me have been trained to examine the thyroid by standing directly behind the patient and wrapping their hands around their neck with the thumbs in the back. And this can simulate strangulation. So why not stand at the patient's side within her peripheral view, fingers fully extended on the neck, and let the patient know what you're about to do and why. In the first photo, I'm checking her heart rate, but my hand is very close to her groin. So in the second photo, I can ask her to extend the wrist onto her knee or have it resting next to her on the exam table. In the first photo, I'm checking the patient's blood pressure, but I'm pressed up against her knees. She's leaning to the side, trying to awkwardly support her own arm, just kind of in her face, and we're in this unintentional embrace. But in the second photo, I'm standing outside of her personal space. I'm fully supporting her arm and she has room to breathe. Having the patient in a completely, 100% supine position is a subordinate position and can activate memories of prior abuse. Now, you can't always fix this if you're in the field and someone's on a stretcher, but in general, if you're able to switch this up, having them the head of the exam table elevated maybe 15, 20 degrees can feel more empowering and like the patient is having a one-on-one normal encounter with another fellow human. You can also offer the patient a mirror for the things that they can't see. There's even a movement towards self-insertion of specula for a speculum exam, self-insertion of swabs for a non-speculum exam, self-insertion of the ultrasound probe for a transvaginal ultrasound, very important. And you can also offer the patient to do their own guaiac, of course, depending on the age, rather than having the examiner be the one to insert their own digit into the rectum. So thinking about trauma-informed language, the first, perhaps surprising word that may not be trauma-informed is the word your. I try to use the word the when referencing body parts during the exam. So it feels very different to hear, now I want to look at your penis, versus I'll now inspect the penis. The means that it's an anatomic body part that I'm going to check, just like I've examined hundreds of other such body parts. It's less personal and zoned in on the patient's body. It's a bit more detached. Saying that it's a bed with sheets can frame the exam in an unwanted, intimate manner. So this is an exam table and this is a drape. Instead of normal, we want to use terminology that's inclusive for exams of reproductive organs, particularly. So you can say that things look healthy And stirrups can resemble a restraint. Think about the emotion, the feeling that is communicated when we say stirrup versus what happens when we hear foot rests. I'm going to be resting here. This is a place of rest and comfort. So looking at these phrases, these are commonly used during the neurologic exam to check motor strength, for example, or reflexes, but they put the examiner in this conflicting adversarial relationship with the patient. So instead, just refer to the motion, resist this motion, or keep the arms up strong, push forward, give them control over their own body parts, allow the knees to relax, bend the elbows. And then finally, for me, is a phrase that I hear constantly throughout the healthcare profession when we give instructions to patients, but it can enhance the power differential that already exists between patients and you, and sometimes it can even be sexually suggestive and inappropriate. Hop on the bed for me, take off your shirt for me, bend over for me, swallow for me. It's just not a necessary phrase. So I have some sample language here. I'm going to press on the front of the neck to check the thyroid gland, and when you can, please swallow. So that concludes during the exam. We'll now move into after the exam. You can thank the patient. Thank them for helping you conduct a thorough, accurate exam. And if the scene allows for it, discuss results once they're seated in a chair of their choice and dressed in their regular clothes, not just perched up on a table with a half-ripped paper gown, right? And finally, ask, what questions do you have? Now here, instead of asking, do you have any questions? Where the patient may feel pressured to say, no, I'm good. I pause what I'm doing. I turn my face away from the computer, open body language, look the patient in the eye and say, what questions do you have? It lets them know, I expect you to have questions and I welcome them at this time. So this is a summary slide of what we've just reviewed for a trauma-informed physical exam. Again, this is just a framework and it's not a checklist that has to be done in order. You don't have to check the boxes for everything you do. And at the end of the day, a trauma-informed encounter is a human-centered one. So just make sure that you are in tune with what your patient's needs and wishes and preferences are, and that everything happens with informed consent, which I understand is more challenging sometimes in the pediatric population. So let's see, how can we apply trauma-informed principles now to our own well-being? Because we just discussed how trauma-informed care can come alive in our clinical care of patients. Let's turn the tables now and think about ourselves, because we do have very difficult, stressful jobs. There are many terms that have been used over time to describe clinician distress, and the list is ever expanding. There's definitely more work that has to be done to help us understand what are these conditions, why do healthcare professionals suffer, and then to put real effective solutions in place to preserve our sanity and to preserve our ability to keep showing up for our jobs. I wanted to share this photo. I really like it. It reminds me of a time when I was a medical student going through my psych rotation. And for some reason, I was tasked with doing group therapy sessions. That was part of the rotation. I had no qualifications to be doing that kind of thing. But I was so struck by these patients' stories. Oh my goodness, so painful. And I realized that if I had lived that childhood, I would have serious mental health challenges too. So I had a hard time processing this. And I asked the attending, how do you do this job? And she said that she views herself as a vessel. And the more she attends to, the more she witnesses, the more she hears and learns, the broader that vessel expands. And she's more and more capable to provide care and assistance to those who need it. Well, that's an amazing thing. And I find sometimes I can do that, but other times it's very challenging. We are witnesses to pain. We are witnesses to joy. We are witness to successes, and we are witness to extreme suffering and despair. And thinking that we'll go unaffected through all of this is like thinking we're going to walk through water without getting wet. So let's just have a moment here for ourselves to give ourselves some grace and recognize that this is an occupational hazard of our jobs. This is one of many models for the dimensions of well-being. This one's published by SAMHSA. Again, I'm doing a lot of SAMHSA stuff today, and I'll go through each of them with a brief comment about how we can be trauma-informed to prevent and mitigate our own secondary trauma as we take care of patients. So the first is intellectual. Realize that the brain, in many ways, governs the health of the body, and that we, to a degree, can control the health of the brain. You can allow negative thoughts to overwhelm and destroy you, or you can observe them, edit them, delete them, and insert positive ones. Usually we're living in one of two places: the past, where we are ruminating about the horrible things that have just happened or have happened in the distant past, or we're living in the future where we're thinking about all the horrible things that are yet to happen. We're hardly ever right here, right now. So use your brain wisely. And if you need help, don't delay in getting help. Physical. Did you know that yoga can be a more effective treatment for PTSD compared to any medicine we've studied? I have many patients who spend 1 or 2 hours in the gym every day as their mental health treatment, and that is very valid and legitimate. Moving the body is a powerful tool for healing and recovery. Environmental. Think about the workplace that you typically spend time in. How does it make you feel? Does it stress you out? Is it cluttered? There's actually a thing called trauma-informed interior design, I swear. And some key principles there is to organize cluttered material in open sight lines, bring in plants or photos of nature. If you're able to access natural light, that's great. And using cooler tones like blue rather than warmer tones like red or orange. Financial. Many of us have a scarcity mindset related to money. There's never enough of it, right? So sometimes having a sense of control over it can help. You can get specific about how much money you need to actually live the life you want, spend money on your priorities, and put plans in place to help finances grow. For occupational, this makes me think about all of the reasons we went into healthcare. And for many of us, as I mentioned earlier, it was serious adversity that got us inspired. There is this concept called post-traumatic growth, PTG, by Dr. Richard Tedeschi, he's the pioneer in that field. And traumatic experiences by nature are transformative. They throw things upside down and make us view things in different ways. And this, in many ways, can be an opportunity. Over time and with a little help, we can learn to use adverse experiences as fuel for growth in new and surprising directions. And we can apply that growth towards our mission-driven commitment to our profession. Social. Honestly, through a trauma-informed lens, this may be the most important circle because healing happens through human relationships and connection. We are built and wired for connection, and isolation in the aftermath of the pandemic is still affecting society. So re-engage in healthy relationships and create new ones. Emotional, and here what I'll highlight is actually the importance of sleep and emotional regulation. Sleep is challenging for so many of you on this call with shift work and overworking and so many things on your plate. You've actually, you've heard before, just sleep on it, you'll feel better in the morning. There's science behind that. Sleep is emotional therapy for the brain. A good night's sleep will biologically soften the rough edges of a stressful event. You'll wake up the next day remembering what happened, but it won't be as emotionally charged. Spiritual. Studies of highly resilient folks show that they are usually connected to some higher purpose, some greater power, or some inner calling. So intentionally connect to that purpose and engage in causes that you find meaningful. At the end of the day, being a healthcare professional is rewarding but challenging. So a few closing tips. Focus on what you can control and don't spend too much time lingering on what is entirely out of your control. You do not have to be a therapist to be therapeutic. I will say that again. You do not have to be a therapist to be therapeutic. We all have the potential to heal and to participate in the healing of others. Use grounding techniques, including the body scan, relaxing muscles that I demonstrated earlier. There are many other versions: diaphragmatic breathing, square breathing, even stretching, counting backwards, whatever it is for you. Start or end the day with a practice of gratitude, which has been shown in research to improve and enhance a feeling of happiness. Please try not to feed or replay negative thoughts. All of those things that you see, the tough stuff that you hear, at least in my experience, it's so easy to bring that home and just have it on replay, but let those thoughts die a natural death. If it is not serving you, try not to continue it, because you could think about it and just be destroyed and nothing changes about the situation. What happened happened to that patient. Or you can keep on living your life, which is probably better for you, your loved ones, your home environment, the next workday, and it still wouldn't change what happened to that other person. Sometimes just being present is enough. You don't have to be God. You don't have to prescribe some cure medication. Sometimes just being there to hold space for that other person's emotions, bear witness to their story and lived experiences, or role model empathy, perhaps in a way that they haven't seen role modeled before. And speaking from a place of empathy, empathy is feeling with someone, and it can be a real superpower in healthcare to connect with the person in front of you. But it does have a nasty side too, if you're always feeling deeply with people, including in their deepest moments of pain. So sometimes shifting to compassion. So instead of feeling with someone, you're feeling for someone, and you're just wishing them well. I hope you get everything that you need. May you be well, may you be safe, may you be free from suffering, may you live life with ease. A lot of this harkens to loving kindness meditations in Buddhist practice. That can be a little protective as we think about secondary trauma. So in summary today, trauma-informed care is an established framework for supporting all of us, and it's a growing movement in this pivotal time in history, that these practices can be applied universally in all aspects of our encounters, and that practicing this kind of work can really lead to a more meaningful experience for patients and for ourselves. So thank you from my heart for your engagement, your participation, your time. If you're not able to get questions answered today, please do reach out to me. You can Google me or find me on this website. This is a QR code to my website. I would be happy to continue this conversation offline and continue learning from all of you. So I believe we have some time for questions and conversation. And I believe someone is going to post a link to a maybe 1-minute survey in the chat. It just helps me to improve my practice moving forward so that I can continue doing this work.
Yes, you got it, Dr. Elisseou. Thank you so much. I'm going to pull up the link and drop it in the chat, and then we'll have our co-moderators will field the questions to you.
Fantastic. Thanks.
Yep.
There's several questions about the name of the books that you've mentioned in your presentation.
Oh, sure. I'm happy to follow up afterwards with a list of resources.
And we will get those resources out to everybody. So just hang on for those. Thank you.
One question that I have actually is about EMDR. What are your thoughts on EMDR for people with trauma?
I think it's a fabulous resource. It is one of many tools in the toolbox. Again, that is trauma-focused treatment, not necessarily trauma-informed. You can be a trauma-informed EMDR therapist, but EMDR is specifically for trauma targeted treatment to mitigate trauma-related symptoms. And for many, many patients, that is extremely effective. For other people, maybe they'd like something different, perhaps fishing on the weekend with their grandfather is enough. Perhaps biofeedback, perhaps somatosensory experience, perhaps other modalities. So that is an important tool.
Thank you.
Do we have any other questions for Dr. Elisseou at this time?
There's a question in the Q&A. It says, what kind of questions and approach would you recommend for a patient in crisis in which we have to do a detailed exam quickly?
Oh, that's great. I think that so much magic can happen within 10 seconds of walking into a room. Just check yourself first. Make sure that you are in your own window of tolerance, and you can get there by doing some kind of grounding exercise, whether it's a prayer or a deep breath, whatever. And then when you enter, eye level, warm tone, open demeanor, soothing voice, eye contact at their level. I'm so sorry you're going through this, but I'm glad that you're here, and I am here to help. We do have to do this exam to make sure there's no other bleeding. It'll be as quick and painless as possible. I am here with you. Even that wasn't a long time, but I'm sure it could go miles in helping the patient feel like they're part of a team, and that they're not alone in this very deeply stressful situation. And collaborating as a team is super helpful too. Maybe you're going to be the one doing the procedure, but then the nurse or someone else can hold their hand while it's being done.
Nice, thank you.
Fantastic. We may have some more questions trickling in, but out of respect for your time, Dr. Elisseou, I wanted to make a few remarks. I've noticed some comments that have come from some of the attendees, and I think this person summarized the appreciation for what you just chatted with some of us. This concept of trauma-informed care is actually new to a lot of people. They may not have actually heard about it, especially in the EMS and the ED worlds. We're still kind of catching up. We're getting to learn about this. And this participant actually said, I want to say thank you. I appreciate the thought of moving from empathy to compassion. I think when our work becomes heavy, that could have a really protective response for us. And I've got to say that resonates with me pretty deeply. My background is in emergency medicine as a provider, and all of us here who are supporting, most of us actually come from the field of EMS or emergency medicine. Talking about this for taking care of ourselves in order to be better for our patients is really an awesome approach. And I thank you for taking that. I think of a quote, be the best you can until you know better and be better. It really resonates with me. And it's something that popped out in my mind when you were speaking. And I think when it comes with children, especially, they make us feel vulnerable when they're sick or hurt. So we're already amplified, and how we come into that encounter, no matter where we encounter them, these techniques that you've provided us, I could see being really helpful. And we wanted to say thank you so very, very much for spending an hour with us tonight. Like Chetty announced a little bit ago, we will be taking any questions that come in. So attendees right now, if you're thinking of more questions or something pops in your mind, please put it in the Q&A feature. We're going to be pulling those right into a document and sending them right over to Dr. Elisseou and every other speaker tonight so that they can fill in those answers and bring us more resources. And we'll be pushing those out to every attendee. So hopefully that helps some folks as they kind of marinate on this and develop new questions.
Thank you so much. Really, it's been a joy, and I look forward to speaking with you afterwards. I have to run to go catch a train.
Yes.
I wish you well. God
Thank
bless.
you, Dr. Elisseou.